welcome everyone. Thank you very much for attending. We're in Dallas today. Next slide, please. So, as always, very grateful for the help of this team, and obviously our overall supervision by Dr. Galantiak. Next slide, please. This is our disclaimer. Next slide. So, Dallas, Texas, unfortunately, for me personally, it's a very big shame that I can't be there in person. And probably the funnest fact for a Melburnian is that you can walk for further than 5 miles from your house and you can get a haircut anywhere you want. But it seems like Dallas is the epitome of go big or go home. It's the home of the tallest cowboy, which I found out was a 52-foot big Tex, home of the tallest indoor Christmas tree, home of the largest urban art district in the USA. Lots of big things. And I was going to ask Dr. Katrina Wells to introduce the city and her team and the hospital. We're very grateful that she reached out for hosting the Journal Club probably about 9 months ago now. And Dr. Wells is a board-certified colorectal surgeon. She did her residency in Brigham and Women's. She did her colorectal fellowship in Wash U in St. Louis, which makes her sample a lot of different states in America, and a lot of different practices, which is very interesting. So if I can get her to speak. Thank you.
Yeah, thank you very much for allowing us to participate in this journal club. Welcome to Dallas virtually. We are very proud of our hospital. As you can see on the screen, that's Baylor University Medical Center in Dallas. It's the flagship hospital of Baylor Scott and White system, which is the largest non-for-profit healthcare system in Texas. We're nationally recognized with multiple accolades, including U.S. News and World Report's Best Hospital, which we consistently receive, and we're ranked in the area of GI and GI surgery, which colorectal surgery is a proud part of. We're a large division. We have 9 colorectal surgeons, and we've served as faculty to a 3-fellow colorectal fellowship program, very busy. We are the second oldest training program in the country, and today, even so, we have a strong tradition of education. We love our fellows, who you'll meet, 2 of which you'll meet today, and we're very proud of the education that we can provide. All of our faculty are very committed to that. So that's about our hospital in a nutshell. Glad if you want to go on to the
next slide, please. Do you want to sort of talk about your partners?
Sure, I'm happy to. So there are only a few included here on this slide, but so Dr. Fiquera is the second discussant for our second paper. He is the chief of the division. Dr. Lichleiter is our panelist, was a previous chief of the division, and now in charge of surgical education. Dr. Fleshman, of course, is our chairman. I'm the assistant program director for the fellowship, and Dr. Parikh and Dr. Dowley are 2 of our 3 fellows who'll be discussing, or who will be presenting the papers.
Fantastic. Thank you. Next slide, please. So we'll start off again with a poll, as is a tradition of sorts, and we're talking about C. diff today. So I thought we could get people's views on the use of diverting loupiliostomy and colonic lavage as described by the team from Pittsburgh in 2011, I think, from memory. So it'll be interesting to see how many people have tried it, how many people use it as their initial approach for patients with severe C. diff. So please say what you do. And whilst we've got the poll question going, let's move on to the next slide, please. So our first paper is elective stoma reversal has a higher incidence of postoperative C. diff infection compared with elective colectomy, and analysis using the NSQIP database. It comes from Washington, DC, and we've got obviously Dr. Parekh as the presenter and Dr. Wells as the moderating faculty. So I'd be grateful if Dr. Parekh can start when she's ready.
Thank you. Advanced slide, please. There is an increase in the prevalence and the incidence of patients who are undergoing a stoma creation, of which half are oftentimes permanent. Clostridium difficile infection, or CDI, has been noted to be one of the most common hospital-acquired infections. There is an association between CDI and diversion or even colon resection. Colon resection has been noted to have an incidence of 2.2% with CDI postoperatively, and the incidence of CDI and diversion has been noted to be even higher. While the incidence of CDI after stoma reversal and elective colectomy is low, it is nonetheless morbid. The objective of this study is twofold. Number one, to evaluate the incidence of CDI in elective stoma reversal versus elective colon resection. And number two, to determine causative factors for postoperative CDI and restoration of intestinal continuity. Advance, please. The American College of Surgeons 2015 NSQIP database was retrospectively reviewed for elective ileostomy or colostomy reversal versus targeted colectomy. A univariate analysis of differences in preoperative variables in patients who underwent stoma reversal or colectomy was performed. A multivariate logistic regression to compare outcomes for stoma reversal versus colectomy was also performed. There were several exclusion criteria in this study: unknown CDI status, emergency operations, preoperative hospitalization stay, and a diagnosis of SIRS, sepsis, or septic shock. Advance, please. This table depicts the most important variables from the study. There were over 12,000 patients recruited in this study, of which 10,400 underwent a colectomy and 2,200 underwent stoma reversal. Younger age, lower BMI, and less diabetes mellitus favored the stoma reversal group and was found to be statistically significant. A postoperative diagnosis of CDI was significantly higher at 3% in the stoma reversal group versus 1% in patients undergoing a colectomy. Superficial and deep wound infections were also significantly higher in patients undergoing a stoma reversal versus colectomy. However, all-cause morbidity, mortality, reoperation, readmission, and length of stay were no different between both groups. The length of stay in patients diagnosed with a CDI was found to be significantly higher at 8 days versus those who had no diagnosis of CDI at 5 days. It is worthwhile to note that patients who had a diagnosis of CDI had a 6 times higher mortality rate at 3.5% versus those patients who had no diagnosis of CDI. Furthermore, patients who had a diagnosis of CDI had a 3 times higher rate of reoperation versus those patients with no CDI at 11%. Lastly, on multivariate logistic regression, it was found that age, smoking status, steroid use, and disseminated cancer were significantly higher in patients who had a CDI versus those patients who did not. Advance, please. In conclusion, stoma reversal has a 3-fold increase in the incidence of postoperative CDI. Patients with a CDI have a more prolonged hospitalization stay at 8 days, a higher rate of reoperation at 11%, and a higher mortality rate at 3.5%. Therefore, expeditious diagnosis is paramount to decreasing length of stay, avoiding fulminant disease, and reducing healthcare costs. However, there are challenges to accurate diagnosis, and this includes the heterogeneous nature of diagnostic testing for CDI, in addition to the difficulty in deciphering CDI from other diagnoses such as fulminant colitis and low anterior syndrome. There are limitations to this study. Firstly, it is a retrospective series. It has observational bias associated with it, and there is a rarity in diagnosing CDI. Nonetheless, the overall purpose of this study is to essentially heighten a clinician's awareness of the fact that patients undergoing stoma reversal tend to have a higher rate of CDI diagnosed postoperatively. Thank you.
Thank you very much. Dr. Wells, what are the key pearls that you've identified in this study?
Sure. I thought this was an interesting study. Clearly, the authors started the study because they anecdotally noticed a difference between diverted patients and primary resection patients with the rate of postoperative CDI that they're seeing. And in their retrospective review of this large database, they demonstrate a difference. It's a possible assumption that there's a difference, but I think there is a caveat. As you can see in table 1 for the selected cases, about 50% of the initial cases that were pulled for analysis were excluded on the basis of not having their CDI variable. So it's hard to know if that's something that is institution specific, perhaps an institution that has a particularly high rate or low rate of CDI, or if it's just a random missing variable across the board for all reporting institutions. You also notice that there's about a 12% exclusion of elective resections for pre-hospitalization, which we recognize as a risk for CDI. So it's possible there is a portion of patients, underreported in the case of primary resection. But assuming that this difference is true, the cause of the difference is unclear. And as Dr. Parikh mentioned, the details of it are really lost in a large database retrospective study. There are some limitations that were nicely and clearly mentioned in the discussion of the paper, specifically whether or not the patient had a previous diagnosis of CDI. And of course, we assume if someone has had an ostomy, they have had some previous hospital exposure, which just inherently increases their risk of having had CDI. We also don't know with this database, the underlying pathology that necessitated the resection and diversion in the first place. Was it diverticulitis, where the patient has had previous antibiotic exposure and probably some alteration in their gut flora as a result? Did they have inflammatory bowel disease, which we know has a high association of concomitant infection with Clostridium difficile, or did they even have a colectomy for fulminant CD colitis, and they're coming now for their endoileostomy takedown with ileorectal? It's also possible, and the authors nicely note, that these differences are due to perhaps an alteration in the fecal flora of the diverted segment, and we don't know in this case whether it's an entire colon or rectum, but we do know that microbiome studies report alterations and reduction in diversity of fecal flora in patients that have had CDI, which results in decreased resistance to colonization. But what to do with that knowledge isn't entirely clear. Of course, we're dealing with a very rare event, but as this paper demonstrates, a highly morbid event. So for practical application, I wonder what intervention may be worth employing for diverted patients. I don't think the data is there to actually recommend a change in practice, but as Dr. Parikh said, have more of an awareness. But some considerations as whether or not we ought to be doing retrograde irrigation of vancomycin to the diverted colon or rectum, or even prophylax with fecal bacteria to increase diversity, like a prophylactic fecal transplant. Again, I don't think that's something that I would change in my practice, but certainly something to think about. I'm also curious to know in this paper what the threefold increased rate of reoperation is in the diverted segment, whether the morbidity seen in the CDI group is due to reoperation for colitis for CDI, or if we're seeing increased rates of leak and wound dehiscence. I mean, we can't capture leak in this database, but whether deep space infection, which we consider a proxy for leak, or wound dehiscence are the causes for reoperation, or if indeed the patients are going for colectomy.
Thank you. Those are very interesting points. There are two things that I want to pick up from that, and we're very fortunate to have one of the authors on, the primary author for the paper, and I apologize if I might not pronounce the name correctly, but Dr. Skanke is on the call. But the two things that I wanted to point out is we talk about patients having an exposure to previous antibiotics and hospital stays, but I found it interesting that dialysis was not statistically significant as a risk for C. diff. You'd assume that those patients are very much colonized with all sorts of stuff. The other thing, to take your point of microbiome, now is this where we should look at, a unit with a biobank to have a look at these specimens? And perhaps Dr. Skanke, if you can comment on those things or anything else you found interesting in your own paper, of course.
Thank you guys for the opportunity to come and sit in and participate in the discussion. And thank you for choosing my article. I'm quite honored. First, to Dr. Goatsman's point, you're exactly right. That's one of the limitations of NSQIP, which is that we are limited by the data. We can't link encounters for C. diff, and prior hospital exposure and antibiotic exposure is very important. You guys are also correct in that the reason we started doing this was an anecdotal experience that our diversion patients were starting to have higher rates of C. diff. That's what a lot of science, I guess, starts from, is you see something and you try to understand what's causing it. What brought us to this was also the concomitant release of recent basic science papers talking about bile acids and how it can lead to the germination of C. diff spores that may be dormant in colon that's unused or underused. And so we were wondering whether that played into all this as well. Now, obviously, we can't make any statements to that extent using the NSQIP database for the reasons that you guys have all very appropriately mentioned. All we can really do is raise awareness, which was very correctly pointed out, that C. diff is a very real pathology for patients undergoing a stoma reversal, even though they may have a significantly less colon present after their diversion. And so I agree that this isn't practice changing. It's more of a keep your eyes out for it, because if you feel like it could be happening, there's a good chance that it could be. And early diagnosis, now whether it's PCR, whether it's toxin studies, or I don't know what each facility uses. I mean, we all have something and they're all usually good at detecting it. And then just being available to start treatment early. I will say the benefit that NSQIP does provide us, just to kind of leave it on a positive note, is I don't think we'd be able to accumulate 15,000 patients where we'd be able to match them. And since we were able to use the relatively stringent inclusion and exclusion criteria, and then a relatively well built out multivariate model, we were able to detect differences of 2% in something that's already very rare. And to prove that with a well built out model, it was statistically significant on regression. So I think that's really where the benefit of the study comes in, is showing on how we can answer a difficult question using the wonderful resources of NSQIP, and then to build on it afterwards. As to the effect of microbiome, I apologize, I'm not that up to date on the current status of all of that, but at the time we were writing this, our main focus, just as an ancillary research to understand what could be going on, was looking at the rates of colonization of diverted bowel, and then the germination of latent spores from bile acids.
Thank you. Now, I've got another couple of questions, and I was hoping to get the panel to give opinion on this. I'll direct it to Dr. Wells, and then she can distribute amongst whoever she thinks is best to answer. So One of the other papers this month we featured was from a group in Toronto, and they talked about the association between preoperative oral antibiotics and the incidence of postoperative C. diff infection, which didn't seem to have an association. But to kind of extrapolate that to an extent and ask you guys, if you are reversing a stoma on a patient with a past history of C. diff, do you change your approach? Do you say, use different induction antibiotics? Do you stop proton pump inhibitors? Do you give prophylactic vancomycin or anything like that?
I'll start by saying that I don't change my practice too terribly much in the pre-hospital setting. So we know that the benefit of, at least in our experience, and well, obviously it's widely reported, but the benefit in surgical site reduction is there for using preoperative antibiotic bowel prep. So I still do antibiotic and mechanical bowel prep for the patients. I give them preoperative IV antibiotics. I wouldn't deviate from those practices, but I think having a higher awareness postoperatively for signs of CDI, and also being very sparing and judicious with any potential need for empirical antibiotics in the aftermath is how I alter my practice with patients who've had a history of CDI. But I'll pass it over to Dr. Fleshman, who may want to comment further.
You know, we've never taken it to that limit where we think that someone who had C. diff before needs to be treated before ostomy closure. If they are still manifesting signs of infection, it might be worth a colonoscopy pre-op and a vancomycin irrigation of the colon. But no, we've not taken to doing it routinely. And it's really it's clinically something that you just have to think about if you're going to do it. And it's a high-risk patient, and they had a rough course with the C. diff in the past, and they were unable to get rid of it. Then, yeah, we probably ought to do something extra, but we've not done it on a routine basis.
Thank you. Sort of going then a little bit further on this train of thought, if you have a person who you suspect has C. diff but has an anastomosis post an operation, are you more aggressive in how you treat them? Do you do anything different to, say, a patient who you've been referred to who just appears to have signs of toxicity without any previous surgery?
Do you want to let Dr. Ficara or Dr. Lichleiter take that one, Katerina?
Sure. Yeah, I don't know if Dr. Lichleiter has joined us yet, but maybe Dr. Ficara.
Well, I want to add a little bit to the previous question, and then I'll answer this one. Large studies, population-based studies, the Michigan Collaborative on oral antibiotics clearly showed that the incidence of C. diff, if anything, in these patients is lower than the patients that do not get oral antibiotics. So I was going to make the same comments that Vladimir brought up. I think the difference here, and this could be a pie in the sky. The difference here is that we prep with oral antibiotics a good portion, and would be interesting to know, although you don't have that information, but it would be interesting to know a good portion of patients that underwent a colectomy versus the ileostomy closure. On the other hand, as we will see in the next paper, a patient who had a bad C. difficile colitis requiring a total abdominal colectomy is very unlikely to have an ileostomy closure. So I guess that in that group of ileostomy closures in this study, not many of them had an abdominal colectomy for concomitant C. difficile colitis. Then to answer your question, I think I'm aggressive anyway with C. difficile. I think is especially now in this day and age of COVID. I've been at Baylor basically just during COVID. I'm very aggressive with C. difficile colitis, anastomosis or not. And I have to say, sort of patting myself in the back, that our incidence of C. difficile infection in our hospital actually is remarkably low, and there is a big campaign on hand washing. So we don't see a lot, but I think we are as aggressive as possible, anastomosis or not.
Thank you. I've got a sort of a personal anecdote of sorts, a memorable case from my residency. And I remember I was assisting in a reversal of loop ileostomy following a routine anterior resection. And the mobilization was very difficult. And we did manage to do a side-to-side anastomosis, although in hindsight, I think we should have done a laparotomy to get greater mobilization of bowel. And so the anastomosis was obviously okay enough because, it was performed and the bowel was, reduced. But the patient then proceeded to have C. diff post-operatively and actually, unfortunately, did quite poorly. But my question is, or my suspicion is, that in some cases, C. diff may be an opportunistic pathogen which reflects perhaps an anastomotic defect of sorts, as opposed to the cause of the anastomotic defect. Have you ever noticed this, or do you think that can be a possibility? Or is this just me blaming our own limited technique?
I would have to say that I don't think C. diff is that opportunistic that it's going to cause an anastomotic leak. However, once it establishes itself outside the GI tract, it's a bear to treat. The issue becomes, is there ischemic tissue for it to establish? Was the mucosal barrier broken down already? And how many spores were present in the colon at the time of the anastomosis? And then I think you might have some data to help you determine whether it was causative or just a secondary effect. We have people who react poorly to C. diff. They go right to an operation very quickly sometimes. We have others who seem to grumble along and they come back with multiple episodes and they never get there. So the genetic makeup of your microbiome of your C. diff may be something that could help you decide one way or another. David Stewart really has spent a lot of time focusing on this. I think he's got a strain or two of C. diff that you just would not want to meet in any dark alley anywhere in the world. And it's just like the rest of surgery. It's better to be lucky than good.
If I can add to the question, John Alverdi and the group at University of Chicago has looked at the microbiome at the anastomotic level in terms of anastomotic leaks, and they have found collagenase producing bacteria, Pseudomonas, Enterococcus fecalis, so on and so forth. And they actually have looked quite deeply into this issue, and I don't think they've come up with C. difficile being one of the players. Granted, they were focusing on collagenase and collagenase producing bacteria, but their work is pretty extensive, and I have not seen C. diff as one of the possible culprits. And that would be actually an easy target, right? If that was one of the culprit, would be an easy target to address, but I've not seen that.
But my point was kind of the opposite, in that I think that C. diff was a reflection of our poor technique than the other way around. Kind of like people with severe ulcerative colitis, which is medically refractory, sometimes get CMV. The CMV is probably not the cause of the colitis, but is an effect. That was what I was kind of worried about in that case. We were blaming C. diff, where in hindsight, it probably was the technique that was the problem in the first place.
Well, you are the host, and I was raised to be respectful of the host. So I was not going to say anything bad about your technique. Maybe in private.
I was very clear that it was in residency.
Oh, now you're blaming your faculty. I see.
Yeah. All right. On that note,
I think I was going to say also but it's an interesting concept because even with E. faecalis overgrowth at anastomoses, I mean, it kind of speaks to an imbalance that then leads to pathology. I mean, perhaps in diverted patients, there's some imbalance that then selects for C. diff. I mean, I don't think it's causative. I'm sure you did everything right, but it is an interesting concept to think about.
Let's move on to the next article, please. So paper 2 is a meta-analysis on post-operative mortality and morbidity after total abdominal colectomy versus loop ileostomy with colonic lavage for fulminant C. diff by Dr. Felsenreich and his team. It's presented by Dr. Dowley and the moderating faculty is Dr. Fichera. So please, Dr. Dowley, if you can start when you're ready.
Good evening, everyone. So this is the first meta-analysis from Vienna Medical University and the Westchester Medical Center comparing post-operative mortality and morbidity after total abdominal colectomy or a loop ileostomy with colonic lavage for fulminant Clostridium difficile colitis. Next slide, please. So the authors wanted to formulate their research as follows using the PICO method. P, population, is patients experiencing fulminant Clostridium difficile colitis. Intervention being a total colectomy. Comparative intervention is a loop ileostomy with on-table colonic lavage. And outcomes, they looked at primary outcome and secondary outcome. Primary outcome is mortality in 30 days. Secondary outcomes were two. The first one was the rate of ostomy reversal. And the second was a composite secondary endpoint of postoperative adverse events being DVT, PE, surgical site infection, urinary tract infection, and respiratory complications. Next slide, please. Methods using the major databases, the researchers put in the terms Clostridium difficile, colectomy, endoileostomy, and synonyms such as pseudomembranous. Their eligibility criteria contained any paper comparing total abdominal colectomy with a loop ileostomy and lavage. Exclusion criteria were any study that was non-comparative, any technical notes, any studies that compared another intervention, or any correspondence articles. They found 134 articles and narrowed them down to 5 articles. None of these articles were randomized controlled trial. 3 were observational studies, 2 were database studies, one being from the NSQIP and the other being from the National Inpatient Sample. Of the observational studies, only 1 was multi-institutional, and only 2 of the studies standardized what lavage was in the loop ileostomy group. Next slide, please. So in total, 2,950 patients were treated with total abdominal colectomy. 733 patients were treated with loop ileostomy with lavage. Looking at the primary endpoint of 30-day mortality, 924 out of 2,950 people had mortality within 30 days, which is 31.3%. This is compared to 192 out of 733 people with mortality in the loop ileostomy with lavage group. This is 26.2%. This was not statistically significant. For secondary endpoints, being ostomy reversal rate, only 2 studies reported this. So the total of patients being compared are 53 patients. For the total abdominal colectomy group, around a quarter, 7 out of 28, had ileostomy reversal. For the loop ileostomy with lavage, 80%, 20 out of 25 had ostomy reversal. And as mentioned earlier by Dr. Fichera, this was statistically found to be significant. For overall complication rates, only 3 studies mentioned this outcome. The total abdominal colectomy group, 313 out of 529, which is around 59%, had a complication post-op, whereas the loop ileostomy with lavage group had 41 out of 110, which is around 37.3%, also found to be statistically significant. Next slide, please. So in conclusion of the paper, there was no difference in mortality between total abdominal colectomy versus loop ileostomy with colonic lavage for the treatment of fulminant Clostridium difficile colitis. However, loop ileostomy with colonic lavage had both a higher ostomy reversal rate and also had an overall lower rate of adverse postoperative events. However, the authors conclude that larger studies are needed that specifically have standardization of definition of fulminant Clostridium difficile colitis, definition of technique, patient selection, and looking at other important outcomes such as recurrent Clostridium difficile colitis after the revision of the ileostomy. Thank you.
Thank you very much. Dr. Fichera, can you tell us some of your opinions about this paper, please?
Yes, thank you, Alex. Good job. I see in the chat, Dr. Gottesman is very passionate about this topic, and I tend to agree with a lot of his comments. Unfortunately, meta-analysis is as relevant as the papers available. And again, unfortunately, what was available, I'm not aware of much more than this, but what was available, it's a mixed bag of studies. The two large databases, we have discussed the limitation of those earlier, but they represent the bulk of this analysis. And for those, we don't have, especially for this group, we do not have detailed information on the severity of the disease, as Dr. Gottesman rightfully mentions in the chat. So that, to me, already is it's a major issue. When somebody is crashing and burning, you tend to be more aggressive. There is no, not only there is no standardization, but there is no definition of severity, and there is no definition of a clear definition of abdominal colectomy, and there is even more so, and more importantly, there is no standardization of colonic lavage through the ileostomy. If we look at the only positive finding of the study, which is the ileostomy closure rate, I don't know if it's possible to bring that slide back. That would be the figure number 3 that shows the meta-analysis on the ileostomy closure. And there are 2 studies that report that. One is the study, that's it, figure 3. The study from NEO, from University of Pittsburgh, which is the most, in my opinion, the most relevant, that has the bulk of the patients, because the other study, single institution, in and of itself, doesn't show a difference. 3 out of 7 and 5 out of 6. I don't think that adds much. In fact, you can see the bar on the right of that. So we are reaching this conclusion out of 3,500 patients or so, based on only the NEO study, which is a great study, but again, is 42 patients. So I have a problem really changing my practice based on this data as a meta-analysis or whatever. The other point I wanted to make, in one of the tables, they look at the severity of these patients, and they have a little bit of a sense based on the Apache score. And there are only 2 studies that report the Apache score. One is the NEO paper, again, which is, in my opinion, of all these papers, one of the probably the best. And the average Apache score was 28.5 and 29.7. Now, an Apache score greater than 25 gives you a 50% mortality. So these patients are indeed sick. However, the other study that reports the Apache score, the Ferrada study, multi-center study, the average Apache score was 16.5 and 22, suggesting, again, considering that these are 10 institutions that contributed to this study, to me means there is a big selection bias in that particular paper. 98 patients, if you divide it by 10, is 9.8 patients per center with an Apache score that indicates that they're sick individuals, but they're not in extremis. So this is really the best they could do with the data available, but I don't think I would change my practice other than use my judgment and try to intervene as early as possible. That would be, in my opinion, the only situation where if you have, right, like we have now, a patient with COVID, a patient immunocompromised, a patient with inflammatory bowel disease, a patient with transplant, which obviously the NEAL study from UPMC, a large transplant population, perhaps intervene early with a smaller operation. But this data doesn't tell me when, why, and why. When and why. So on that, I will stop talking. I don't know if it's okay to ask Dr. Godesman, who is very passionate, to make a comment, but I'm going to give it back to the moderator. Thank you.
Thank you. I think he's got his headphones off for the moment, looking at the screen. So we'll wait for him. Now, can we go to the poll results? Because I think it would be interesting to see what people actually do, not necessarily based on this study, but based on the disease. So maybe Stephen, if you can have your time to shine.
I am sharing the results. So so yeah, the poll was pretty heavily geared toward, is it sharing with everyone? Pretty heavily geared toward answer number 2, that there are a large number of people aware of the protocol, but who have not used this specific ileostomy treatment. There are certainly a couple of people at the bottom that have tried it, and there is one person who has has this as their preferred choice for treatment. So a lot of people in the group are aware of it, but not a whole lot are using it, at least routinely.
Thank you. So I'm going to plug the section of the DCI journal called Resident's Corner. I quite like reading some of the articles, and there's an article which was co-written by Dr. Fichera. I can't remember how long ago, I think 2020, fairly recently, about C. diff infection. And the article has a nice flow chart, particularly for people sitting their boards. That might be quite helpful in terms of their decision making and what to do when. I personally am in the aware of protocol but have not tried it camp, and I would find it very challenging to determine when surgery is indicated, but limited to diverting loop ileostomy and lavage. One of the things that I also don't quite understand is, I guess we're using the lavage as a form of source control, but in no of the studies there's any comment about diverticular disease or any other conditions that might prohibit adequate irrigation. And I wonder if there is anyone who does like this as their preferred option, whether they can comment on that. Or if anyone's passionate against it, comment the other way.
I think I was the only one who said this is my preferred option, and I feel bad about that. I think Dr. Fleshman and I may have been the only people who listened to the original paper at the American Surgical, but I was incredibly impressed. It was a very carefully done study where at the time, at University of Pittsburgh, all their patients were literally dying or had an incredibly high morbidity, and they basically wanted to see what they could do to decrease their morbidity. And on the occasions where I've used this, it's worked wonderfully well. The nurses hate it because it's very intensive of nursing, critical care nursing time in terms of doing the vancomycin flushes, but it works extremely well. Sorry, I try not to intrude during Journal Club, but couldn't resist that comment.
I think this is a great show of how we can easily skew a vote if the president votes one way. Anyway, I've actually got a question to that effect then. I haven't read in any of the studies how they came up with this idea. Is this the evolution of a Turnbull blowhole colostomy where they changed the blowhole component to irrigation as source control, or what was the thought behind commencing this? Would you know, Dr. Galandiak?
They basically saw that they had such a high morbidity from their colectomies that they tried to do something else. And they thought if they could eradicate the C. difficile from the colon through another means, and they were basically just trying to irrigate the colon with vancomycin flushes. And it worked. I mean, intraoperatively, it's a laborious procedure. And I am old enough that I am very jaded. And I think one of the reasons why this hasn't caught on is the idea of financial reimbursement. Because if you do an ileostomy, it's very much less well reimbursed than if you do a colectomy, at least in countries where there is a fee for service.
That's interesting.
So
I've got a, sorry.
This is Jim Fleshman. I was in that American Surgical meeting, and I was the one that was criticizing the paper. So my comment to them was whether or not they had actually tried colonoscopic irrigation of the patient with vancomycin or even saline before they went straight to an ileostomy. And while I don't remember them being all severely ill, I thought some of them might have actually been earlier in their stage of their disease, Susan. But I think that's one of the issues we have. We have a lot of options, and we go right to surgery once a couple of things happen. The white count goes up and the patient gets sick, then we stop trying anything else. And I actually equate ileostomy irrigation with colonoscopic irrigation. So at WashU, when I was still there, we hardly ever took out colons for C. diff, and Steve Hunt had quite a series of patients that we had done colonoscopic irrigation and avoided colectomy. So that was my opinion of the paper when I first heard it.
Yeah, although what they described intraoperatively is the 8-liter irrigation with Golightly, which is a very large volume irrigation. And I don't think you can easily get that through colonoscopic irrigation.
Thank you both. One last question before we move on to the next segment. I've noticed that the mortality rate in this paper for total colectomy was 31%, for lavage was 26%. So irrespective of what you do, clearly these are very comorbid sick patients. My question is, what happens when these types of patients walk in back to your office and want to be restored? What do you tell them about the risk of C. diff recurrence? And I mean, sort of marrying the first paper and the second paper, would you do anything different? Are you more likely, if it is an ileorectal restoration, to give them a diverting loop ileostomy at that time? Or do you just treat them clinically on the day? Katrina, I'll subject you to decide who who to send this one to.
Don't do
it. Sure. Well, my 2 cents, I will say they don't come into my office very often requesting their ileostomy reversal because they don't tend to survive. And if they do, we thank our lucky stars and don't tempt fate again. But I'd be interested to know what Dr. Fichera does.
Well, I don't do ileostomy, so it would be just to take down, not just, but to take down an ileorectal. And as you know, the more debilitated patients are the ones that don't do well. I've had patients that have had C. difficile requiring colectomy for ulcerative colitis, superimposed C. difficile dose. Then I proceed to the next step of the procedure if they are pouch candidate, but that's a minority of the minority of the patients that we see in the hospital with fulminant C. difficile colitis.
Thank you. So let's move on to the next section of our chat, where we have a special guest who today is Dr. James Flashman. He's got a phenomenal biography of achievements. He's been the president of ASCAS, been the president of the American Board of Colorectal Surgery, president of ASCAS Research Foundation. But what I found today, which was most interesting, is that he wears cowboy boots on Fridays. But the aim of this discussion is to focus on the Z6051 trial, where he was a key player, but not so much to discuss the significance of the trial. We all know it's a seminal paper published in JAMA, but more to sort of pick his brain about the mechanics of undertaking this trial and seeing it to completion. And so my first question is, when and how did you decide on running this trial, and how many years did it take from conception to completion?
Well, thanks, Vlad. First of all, thanks for including me in this. And I want to congratulate Dr. Daly and Dr. Parikh on some excellent presentations. As soon as the colon trial, the cost study trial was over, we all started talking about rectal cancer. What are we going to do about rectal cancer? We had to decide whether rectal cancer was different from colon cancer. And the discussion was around, is it equivalent in terms of ease of minimally invasive approach? And we all agreed that it wasn't. There was not a consensus that minimally invasive surgery for rectal cancer was the next step. So we felt like we ought to at least put it to test. So to Heidi Nelson's credit, she allowed us to start a protocol. And when she became the head of the American College of Surgeons Oncology Group after Dr. Wells stepped down, she told us to go ahead and put that into gear. So in 2001, we started writing our protocol. David Dietz took it to the GI committee several times for me when I couldn't make it, but we waited 8 years from the time of starting the protocol to the time it was finally approved and we could move forward. The writing of a protocol really is not easy, especially when it's going to be attached to a $3 million request to the NIH. So Heidi gave us Dr. Anne-Marie Buller, who was in Chicago at the time and was an outstanding asset. She and I went back and forth on a daily basis, writing this protocol, honing it. I had an executive committee that was really looking at every change we made. Every meeting that we had we could all gather together, the ASCRS, the ACS, the SAGES, SSAT, Society of Surgical Oncology. There was always a group of people there who wanted to sit down and talk about putting that protocol together. And so it was clearly a joint effort. I had an executive committee that worked with me. Just for example, John Monson, John Marks, Steve Wexner, Tom Reed, Peter Marcello, Mark Whiteford. It was a joint effort. Everybody was sold that we needed to get the right answer for this question. Had I tried to do this on my own or tried to establish a protocol and put it through without the backing of the entire Society of Colorectal Surgery, it would have been a mistake. And the reason we even got the trial done was because of the commitment of the colorectal surgeons in our country. And we designed the trial so that it could be duplicated elsewhere. So Andy Stevenson and Galt Bonger and a Korean group all took it and put it together. And we're going to have a meta-analysis soon of a metadata analysis soon to see if our conclusions are correct. But that's how a trial worked best for us and how I think we can all feel comfortable with the outcome.
Thank you. That's a very, I didn't appreciate how, I know it took a long time. I didn't appreciate how long. You mentioned that you sort of had a $3 million budget. At what point does one decide on a budget for a study? And, how do you keep within budget? Not only for something this massive, but for smaller studies that people might want to do, smaller RCTs.
Well, it starts like any clinical trial, prospective clinical trial should start, which is calculating your sample size. And I know you've got some questions about how we did that, but if you know that this is going to be a capitated trial so that each patient is going to be paid for with a certain amount of money, you have to be able to meet that. And you can calculate the needs of a trial based on the amount of data that's going to be collected, the number of times the patient's going to be seen, the number of people that will be involved in caring for that patient, and then the background noise that goes into statistics and data cleaning and a data safety management board and travel for the study group back and forth. It adds up, and I was very fortunate that CTEP, which is the Clinical Trials Evaluation Program, was interested in looking at our technical trial as the next, I guess, the next stage of doing prospective trials. And I tell you, Dr. Nelson is an amazing human being, but she's also a genius in my opinion, because she figured out a way of getting this through the NIH process in such a way that they really wanted to do this trial. So I wasn't having to knock down any doors to get things done. It was there, it was ready. And she really is due a lot of gratitude and a lot of respect and congratulations for what she did for us to get this done.
Okay, thank you. That's interesting. Focusing on the methodology of the study, it is a non-inferiority trial, meaning, obviously, you know, but laparoscopic rectal resection being non-inferior to open. How did you settle on this compared to, say, an equivalence or a superiority trial? And specifically, I asked this, there's an interesting publication by Nancy Baxter's team in JAMA in about 2018, talking about interpreting non-inferiority trials, and they mentioned this one and also the Stevenson-Ellicott trial, and they demonstrated that the results were often misinterpreted in other papers, of which they quoted 71, and they described them as being quite ambiguous in their language. So what do you think about the methodology?
So Dan Sargent was the chief statistician for the American College of Surgeons Oncology Group and later the Alliance, GI Alliance. No, just the Alliance. And the idea is that if you wanted to do an equivalence trial, you would have to have close to 3,000 to 4,000 patients. If you do a superiority trial and you get no result, then you still don't know whether or not it's equivalent or whether you just failed to pick the right process. So a non-inferiority trial was based on the fact that if you look at a lot of the medical oncology studies, they are banking their conclusion on a 6% difference between the effective group and the ineffective group. 6%. Now, if you think about that, that's not a lot. And they're staking people's lives on that all the time. So a non-inferiority trial actually takes that 6% and says, if you can't get within that 6% and be close enough into the study group, well, then you really need to say that there's no difference and maybe there's no benefit. And so that's how the non-inferiority trial came along. Instead of 3,000 patients, we could do it with 800. And we could get it done in a period of time that was reasonable for us to be able to report it and it not be completely, irrelevant, which it almost was, because robot came out right at the end of it and people were already making the switch to robotic proctectomy, and we still didn't have our data out for the laparoscopic approach.
maybe it's difficult for you to answer this, but if I'm not mistaken, the a la carte trial, they comment on a non-inferiority difference, meaning lab being worse than open, was 8% compared to yours being 6%. Like, how does that work to a simple-minded person like me? Because it's the same operation.
Andy calculated what they felt like was a reasonable difference that they could hang their hat on, and I think it's the Australian GI tumor study group said that they wouldn't do it if it wasn't 8%. So he said, fine, 8%, whatever. The 6% was something that the NIH, the NCI, and every cooperative study group had been using in the United States for a long time. So there were no raised eyebrows when we suggested that. So if we said, if the open group could get 90% complete TME and complete distal margins and all the lymph nodes, then if you could get at least 84% with the laparoscopic approach, then it would be within the range of saying that there was not a lot of difference. And you could call it almost, you could call it a non-inferiority trial. So the laparoscopic arm wouldn't be inferior to the open group.
Just taking you up on the distal margin point, I think in the trial, the negative distal margin is greater than 98%. For me, I always worry about having a positive distal margin, and thankfully so far, the only times that happened, I've woken up in a cold sweat. And so it's never actually, never actually been on the pathology report per se. But how do you think, can we actually get to 100? And it seems to me like it's a preventable issue.
It's a preventable issue if everyone gets an abdominal perineal resection. Think about it that way. So reconstruction has made us compromise on saying that we want a 5-centimeter distal margin for every case that we do. During that time period, as we were trying to decide what to do with this distal margin issue, we actually noticed that there were people who were being forced to do APRs because they couldn't get a 2-centimeter distal margin, which was our original plan. After chemoradiation, we think that a negative margin is all that you need. And there have been plenty of studies that have confirmed that. But the problem is that you cannot tell if there's a single cell island sitting where you make your staple line just because there's nothing on the mucosa. So we're going to live with the 2% forever, in my opinion, because I can't, in good conscience, tell people that they have to have an APR and a permanent colostomy just because I need 5 centimeters below a staple line in 98% of the time.
Thank you. That's very clear. In the trial, you conclude that pending clinical oncological outcomes, the findings do not support the use of laparoscopic resection in these patients. Was this unexpected or expected for you?
So we did not expect so to get into this a little deeper before I make my statement on that, we originally thought that there would be no difference, and we intentionally made all of the tumors within 12 centimeters of the anal verge. So that means that the majority of tumors were either in the mid or low rectal area, not in the upper rectal. Now, I don't mean to criticize wrongly, Jaap Bonger and the European group, they allowed upper rectal and rectosigmoid tumors and made their statement based on those. Andy and the Korean group and I decided that we really needed to know what the mid and low rectal tumors were going to do So we insisted that that be 12 centimeter margin, or 12 centimeter site below 12 centimeters in the rectum. If you go into that, what you find out is that as you look deeper into the data, the majority of the problems occurred in the low rectum. We were not allowed by JAMA to say that it's wrong to use minimally invasive surgery in the low rectal cancers. But we were allowed to say, and actually encouraged to say, that we could not, in clear conscience, say that there was no problem with minimally invasive surgery with rectal cancer. So some way we had to hedge. So when we published our data, the outcomes data, the cancer outcomes data in the Annals of Surgery 5 years later, that was 3.5-year survival. There was no change in the overall survival. There was an increase in local recurrence in the low rectal cancer group. And now, I think if we get the data from both of our trials and combine them, that there will be a significant difference in the low rectal cancer with minimally invasive surgery, and we may need to change our statement.
Okay, and so sort of going further with this, do you think that the approach to rectal cancer surgery is evidence-based? And, you know, has your views been challenged by running this trial?
Well, my views were, I thought that we would be able to achieve technically the exact same outcome with a laparoscopic approach and an open approach. I really think that for me to do a low rectal cancer minimally invasively is probably inappropriate. And I will do a combined hybrid approach where I do a mobilization of the splenic flexure, mobilization and ligation of the IMA, and then do the pelvic dissection through a fan and steel open incision so that I can actually have a trained hand in the pelvis and know exactly where my margins and my planes are going and know where I'm putting my stapler across so that I feel like I'm using a minimally invasive approach for the patient's good, but I'm using an open approach for the cancer treatment portion.
Okay, thank you. And again, I'm very junior in the scheme of things, but I think sometimes the difference between the dissection and the transection is significant, where the transection's a lot easier to do open, which is not necessarily the same for the dissection. But I'm going to leave you with one last question, particularly given that you've mentioned collaborating for the meta-analysis with the other continental trials. What do you think about sort of colorectal surgeons trying to do more collaborative RCTs around the world? Is it feasible, given the differences in the ways, arguably, these medical systems work? Do you think it'll give us better results? Do you think it's going to be less relevant to any local body?
I think it's this is a global healthcare system now. It's not national, it's global. We have to be held responsible to our colleagues across the world. The way this happened was based on the tripartite meeting. It was terrific. Andy and his crew were there, and we went out on a tour of the bay, and we swapped protocols, and we talked about what we should do. And I have to say that if we hadn't done that, I would have felt really that we didn't have an answer, because it could have been just the American patients that we chose. I mean, obesity, narrow pelvis, we had a predominance of males in our group, et cetera, et cetera. had Andy not done it in this with using the same protocol with a single variance of having 8% difference versus 6% difference, I think we would have had a mistake. We would have not gotten the right answer. So I would encourage the next generation of colorectal surgeons to really think about the collaborative effort that could be made that would benefit all of our patients throughout the world.
Thank you. I think that's a wonderful concluding statement. Thank you very much for your time, and thank you to the team in Dallas for hosting this event. I think it was fantastically run. I personally have learned quite a bit. And thanks everyone for joining in, and hopefully hello to those who are going to watch it on YouTube. Next month we're going to Mayo, Florida. I think there is a meeting on in the States, the ASC meeting, isn't it? So we might have to change which Monday we do it on, but we'll keep you guys posted on Twitter. Okay, so thank you everyone.
Thank you, Vlad.
Have a good day.
Thank you.